Hi guys, welcome to another lecture, and today we'll be discussing something about ECMO. So extracorporeal membrane oxygenation is a technically recent advance in our country. It has been used, it was first started in 1970s, and after COVID, it has gained a huge popularity. So ECMO is important, extracorporeal membrane oxygenation, and I have tried to simplify this lecture so much that you can easily copy this in your exam, and you will be able to fill 4 or 5 pages very easily. Okay. So what is ECMO? So ECMO is essentially, for layman people, it is something like a bypass. It is something like a cardiopulmonary bypass in which you put out the blood. The blood is taken out from the body. It is oxygenated by a machine, and the work of the cardiorespiratory system is done by that machine. Now, which respiratory function is done by the machine? Oxygenation. And which cardiac function is done by the machine? That is pumping or providing pressure, or to maintain the circulatory system. So these two functions are the reason why ECMO is used. So as you can understand that in any condition where oxygenation is impaired, and when circulation is impaired, we can use ECMO. So that is all in all the summary of this lecture. Now we'll begin with the lecture. So as I told you, ECMO was first made and it was used in 1972. Okay, and it was used in a child. It was first used in a child who was operated case of TGA. During that time, arterial switch was not there. They did the mustard operation, and the child was a patient operated case of TGA. And then once it was established that it can be, see, initially there was very high amount of mortality, and the ECMO received a very bad reputation, but later on ECMO was used in meconium aspiration syndrome in a newborn, and after that multiple studies were done, and then there was a ELSO organization, extracorporeal membrane oxygenation. Okay, extracorporeal membrane oxygenation or extracorporeal life support organization, that is ELSO, extracorporeal life support organization. Okay, so this was the ELSO association, and under it, the ECMO centers have to register themselves. So all in the under this ELSO, we have around 450 to 500, somewhere in between the number of ECMO centers are there. Now let's begin the original lecture. So there are two types of ECMO. Types of ECMO, there are primary two types. There are actually three types, but two types are commonly used in pediatric. So one is veno-venous, and second is veno-arterial. Okay. So what does veno-venous mean? That we take out the blood from the vein and we put it again in a vein. Now again, veno-venous and veno-arterial are of two types. Okay, but before understanding that what two types are they, we will understand that when they should be used. Okay, so veno-venous, we take the blood, blood is taken from vein and it is again given in the vein after oxygenation. Okay, so this is primarily used, in respiratory abnormalities where oxygenation is impaired. Using the respiratory abnormality, this is gross rule. Okay, I have made it very simple for you to understand. And veno-arterial is used in cardiac disease. Why? Because see, when you are putting the flow back into the arterial system, you are maintaining the blood pressure. You are, ameliorating the shock. Okay, so that is the advantage of veno-arterial, that you are ameliorating shock. But veno-venous, what happens is, see, venous system, whenever there is a volume overload in venous system, then venous system can accommodate a huge amount of blood. So that is advantage of veno-venous. That why do we use veno-venous more frequently? That is because veins have a good capacity to expand and contract. arterial system are not that elastic. So they should be only used in cardiac disease when there is shock-like symptoms. Veno-venous is commonly used when you have respiratory abnormalities. Okay. Now they are further of two types. Both have same, headings. So central peripheral and central peripheral, same. Okay. So in veno-venous, okay, in veno-venous, the intake and the outflow, okay. So the blood outflows from femoral vein, okay, and it inflows back in the internal jugular vein. Okay, so the reason I wrote peripheral first is that now you will have a question that if IJV and femoral vein are the periphery, then what is the center? Okay, so central is that it goes in from pulmonary artery, and outflow is there from right atrium. Now, once you have understood this, you have to understand that the central type of ECMO, the central type of veno-venous ECMO requires sternotomy, because it is essentially a cardiac surgery, because you cannot put something in RA or pulmonary artery just by easy methods. Okay, you have to go further. In pulmonary artery, you have to go further. Okay, so that is why you have to do a sternotomy. While peripheral, the advantage is that it can be used by minimal access surgery. Okay. Now, in central and peripheral in cardiac disease, okay, in the not on the cardiac disease, rather in VA. Okay, in VA, in the central axis, we take out from the RA and we put in back from the aorta. Okay, so that is what we do, and it is the same, nearly same for the peripheral axis, that we take out and in from the femoral and the jugular supply. Okay, it is the same. I'm not writing because it is the same. Now, whenever you are asked in exam, I would suggest you to draw this image. Now, this image I am drawing, this image of a child that I'm drawing is a V peripheral axis. Okay. Okay. So this child, okay, this ugly child, he has a VV peripheral axis. Okay, so blood is taken out. The blood is taken out from femoral vein. Okay, and there is a centrifugal pump. Which oxygenates, which actually circulates the blood, which is later oxygenated. Okay, you can draw another. It is just one machine, but you can draw another port. So there is oxygenation, and it goes back via the IJV. Okay, we missed drawing the neck, so you can just understand that it goes back via IJV. So this is actually how it works. And if you draw this image, whenever you are asked about ECMO in exams, then the examiner gets an impression that you know something about it, at least if you draw this image. Obviously, you can extrapolate this image to all four of them, like central VV, peripheral VV, central VA, and peripheral VA. You can extrapolate this image. Just intake and outtake you have to change, and the centrifugal pump and the oxygenator remains the same. Okay, so this is just the image, and I hope you understood about it. Now, what are the indications of ECMO? So as I told you, you can just guess that what are the indications, but primarily the indications are divided into two parts. One are the respiratory indications and second are the cardiac indications. Okay, these are all pediatric indications. Adult commonly ECMO is used. Pediatric, obviously we did not get that severe ARDS patient with COVID-19. So during COVID, pediatrics, did not have so much hands-on with ECMO. So first is airway indications. So when there is obstruction, severe airway obstruction, okay, there is a severe laryngeal stenosis, or there is a presence of a web which cannot be broken. So that is when you have to use this, okay, or when you do a tracheoplasty. It is, the name is very, very easy. Like you can understand that trachea is remade, tracheoplasty. Trachea is remade by the plastic surgeon or by the ENT surgeon, and till that the trachea, it reforms, or it joins the contact. Till that we have to give some rest. So during that, ECMO can be used. Then there are pulmonary indications, lung indications, like bronchopulmonary fistula, broncho plural or bronchopulmonary fistula. Okay. And next is severe ARDS, severe pneumonia. Then there is inhalational injury, soot in trachea. FM days, I hope you remember. Next is that pulmonary hemorrhage, severe pulmonary hemorrhage. Okay. And meconium aspiration syndrome, congenital diaphragmatic hernia. Okay. So these are the lung indications. And the third are end stage respiratory failure as a bridge. Now, what is the meaning of this? This is that this is used as a bridge therapy. That until you give the patient lung transplant, the lung is until you can give lung transplant to the patient to keep the patient alive. This can be used as a palliative or a temporary therapy. Okay, and then permanently you can transplant. You can do the transplant. Okay. Then next is cardiac. So failure to wean from bypass. Like you have put a patient on a cardiopulmonary bypass due to any indication, and then the patient cannot be weaned off. Okay, so at that time you can keep the patient on ECMO. Okay, then next is as a bridge therapy. Again, when you have a patient planned for cardiac transplant, so during that, this can be used as a bridge therapy until you wait for the availability of either ventricular assist device or a transplant, cardiac transplant. Okay. Third is cardiomyopathy, irreversible cardiomyopathy. Again, it can be used as a bridge therapy, or myocarditis or sepsis, or massive PE, severe PE, massive PE, where the heart has failed. And then trauma, contusion, like lung contusion or cardiac contusion is also an indication. Okay. Now, what are the contraindications for ECMO? So again, there are two contraindications. One are the absolute contraindication, that you do not have to think about ECMO. Okay. So there are three absolute contraindications, and all three are essentially same. That if the patient has an end-stage disease and there is no hope of survival, like the patient has irreversible damage or irreversible metastasis, stage 4 metastasis, then there is no point in prolonging the life, because this ECMO also is you cannot use it with everyone. Like it is very limited. So just reserve them for those who have good prognosis. Okay. So first is irreversible brain injury. Like the patient is brain dead. So no point. Like the patient will stay on the ventilator and you do ECMO, and what is the point? Like that. Okay. Then next is mets in malignancy. Stage 4 usually have the worst prognosis, and there is an end stage organ failure without transplant. Like the patient has liver failure and you do not have, the patient has multiple other contraindication and there is no hope that you will get the liver on time to save the patient, then there is no point in prolonging the life of the patient. Because unlike renal failure, liver failure can, you cannot give dialysis to the patient that come after 10 years, we'll get kidney by then. You till then do dialysis every week. So it is something like that. Okay. Now, what are the relative contraindications? So, MODS, severe MODS. Okay. Second is that coagulopathy. Now, why coagulopathy is a side effect, contraindication of ECMO? Because it is also a side effect of ECMO. And when you do ECMO, there are the coagulation system goes into overdrive and there is very high risk of, the patient will die of a massive embolus or thrombus, because ECMO itself increases the chance. Plus, if there is already a coagulopathy, already the patient is in severe DIC, then there is very less chance that patient will survive. Next is severe immunocompromised state. Fourth is severe AR, and fifth and the last is that there is aortic dissection. Now, in these two conditions, these are specifically contraindication for severe aortic dissection. These are contraindication for VA access, and you cannot survive the patient because there is patient is in so much shock that whatever ECMO you do, they will not be able to survive it. So that is why you can counsel the patient about the severity of the condition, and then the patient's decision is that. Okay, now you have to know that what are the effects of ECMO on. Now there are two systems that ECMO affects the most. Again, the same to RS and CVS. Now in RS and CVS, in RS there is increased deoxygenated blood because there is a amount of shunting there. Okay, there is increased deoxygenated blood, and the target SpO2 should be more than 80. Not, you cannot plan that it should be more than 90. More than 80 is good enough for a VV ECMO when you have an RS system, because there is increased shunting of blood. So due to that, you have higher chances of lesser SpO2. So that is the effect. But the important effect that I want to draw your attention to is that in CVS, right ventricular failure or left ventricular failure can occur, and pulmonary embolism can occur. Higher chances of pulmonary embolism and also pulmonary edema. Because if you do not decompress, see, VA ECMO is essentially done to decompress the left ventricle. The ECMO takes the blood from the, imagine that in VA ECMO, what happens is the blood is taken from right atria and it is put in the aorta. So completely bypassing the heart. Okay. Now, in case when you have a CVS failure, you have a CVS failure and you have done a VV ECMO. Okay, so here you are not bypassing the heart, and due to that, there is higher chances of you are exacerbating RVF and LVF, because so much blood is coming that RVF and LVF are already not functioning properly, and you still are giving more blood. So, in case when you have a cardiac failure and you give VV ECMO, there is higher chances of pulmonary edema, pulmonary embolism, RVF and LVF. So this is what you need to know. This is primarily in the VV ECMO, not in the VA ECMO. VA ECMO is ideally to bypass the heart. When the heart is not working, it is very, very beneficial. Okay, so this is important. So how to treat this cardiac failure? If left ventricular failure occurred, left ventricular failure has occurred. Okay, so how to treat it? So you can give inotropes, you can give intra-aortic balloon pump, okay, or you can decrease the ECMO flow. ECMO blood flow. Okay, or you can do a atrial septostomy. Atrial septostomy to decrease the overload on the pulmonary edema, to decrease the pulmonary edema. Okay, so this is important. Now, what are the complications associated with ECMO? So again, the complications can primarily be divided into two parts. One is the circuit related or the technical complications, and second is the patient complications. Okay, so circuit complications include that you cannot gain access, you failed access. Like same, you cannot get an IV line in some patients. In this also it can fail. Second is that IV cannula gets displaced, or there is pump failure, the machine failed, or oxygenator failure. So these are the complications. These are not important. The important are patient-related complications. So there are primarily three types. One is the hematological complications that I stressed on, that there are very high risk of thrombosis. Okay, very high risk of thrombosis, and thrombosis very high risk. And again, when this thrombosis occurs in high amount, then it will lead to hemolysis, and it is called as DIC, obviously. So at one place it is clotting, and at one place it is not clotting. So that is what can happen, and that is very common hemato-oncological complication. Next are the neurological complications. Now, neurological complications are the one that are now being very, very much focused, because as you can understand that in pediatric population, if there is a newborn with MS, so you gave ECMO and the patient had a stroke. The patient will, the patient will manifest in a later stage, and that the developing brain may get injured, and the child may end up being a handicap for rest of the life, and you are inviting a case on you. So that is very, very important. So neurological, again, seizures, ischemia, or stroke, or intracranial hemorrhage. Again, the same, hemolysis or bleeding, or coagulation or thromboembolism. Okay, and the third is left ventricular distension, the cardiac complications, or iatrogenic infection, or there might be ischemia. Now, why there should be ischemia? Obviously, you are gaining an arterial supply, and if the arterial supply will go into a reflex vasospasm, then as you might know, that if you put an umbilical artery in a newborn, then it may lead to blackening of that same limb, because reflex vasospasm may occur, and in arterial supply, that is the risk that once vasospasm occurs, there is a big issue. So this is very, very important, and I hope you understood it. Now, how to wean a patient on ECMO? Weaning on ECMO. So again, two types of how to wean. One is how to wean a VV ECMO, and how to wean a VA ECMO. Okay. So in VV ECMO, what do you do is you decrease the oxygenator fresh gas flow. Okay, so what happens is that you kept the FiO2 of the oxygenator, like as we saw in the diagram, there is an oxygenator which oxygenates the blood outside the body. So you decrease the amount of oxygen in the oxygenator, and you increase the amount of nitrogen or air. Just as we change the FiO2 of humidifier, we can decrease the FiO2 of the oxygenator. So we gradually decrease the oxygenator fresh gas flow, which will essentially decrease the FiO2 of the patient. And just as we wean the patient from the ventilator, in the same way, we will decrease the FiO2, and once it is on 21% or no oxygen is done, until that happens. After that, once it happens, then you can wean the patient. Okay, so that is how you can wean the patients. While in VA ECMO, we decrease the flow, and then we check for markers of organ perfusion, markers of organ perfusion and hemodynamics. Like we decrease the flow, and then we check the BP, we check the SpO2, we check the peripheral SpO2, we check the MVOS. By the NIRS. MVOS is mixed venous oxygen saturation. So these are the methods, the same methods that we use to quantitate the shock. Okay, urine output, central venous pressures. So all these markers are taken, and once these markers are stable with decreased flow, then you can gradually wean off the patient from ECMO. So these are the two important parameters to check for weaning in ECMO. Okay. Now, next is how to follow up the patients of ECMO. So long-term follow-up is very important in ECMO because there are very high chances of patient having a permanent disability, because the ECMO is not physiological and there is very high chances of complications. So that is why you have to keep the patient on follow-up. So how will you do follow-up? So 3 months after discharge, you have to evaluate everything. And this is primarily for neonates, okay, not for pediatric, because in pediatrics you can call them earlier. In neonates you have to quantitate the developmental markers. So 6 months and 1 year, these are the mandatory follow-up, and these are the long-term follow-up which you have to do, because permanent disability may occur and then you are inviting a litigation for yourself. So that is an issue. Okay. Now, what are the complications in the survivors? Complications with survivors. Now see, this is a relatively newer technology, so we do not have very long-term follow-up, because obviously if I tell you that if it was found in 1970, it was probably 1990s when it was widely used. So nowadays those patients might be of 20-30 years, not more than that. So long-term follow-up, again, they require some more years. But these are the few known long-term complications, which include CKD, stroke, sensory neural hearing loss, reduced exercise tolerance. Okay, so this is a very common side effect, and this is seen in this reduced exercise tolerance is seen in around 100% of patients after 3 to 5 years. Now we do not know why. Many hypotheses have been put that why it could have occurred, but see, you have to know that 3 to 5 years after that, there is, patients have this exercise intolerance invariably. So that is a very common complications. I hope you learned something about it, and that's all for today, guys. And I hope I'll see you in the next one. And I hope you learned something new about in the lecture of ECMO.